This conference will now be recorded.
Hello, I'm Dr. Sanjay Dadamani. I'm the Chief Physician Executive and Chief Operating Officer of Southwestern Health Resources here in Dallas, Texas. Southwestern Health Resources is the clinically integrated network between UT Southwestern, an academic medical center, and Texas Health Resources, a large community-based healthcare system across northern Texas. And together they came to form this clinical network of independent physicians, primary care, and specialists, really under the umbrella of value-based care. We have been year over year the nation's #1 next-gen ACO for shared savings, and have deep experience in having participated early in the Pioneer ACO back in 2013-14, and have continued along this journey of value-based care. We own a small health insurance Medicare Advantage plan and participate in fully capitated arrangements with the major payers. And so I'm really pleased to come here and share our own experience of the pandemic of COVID-19 really creating an urgency and bringing us together to help leverage the tools and resources needed to be successful in value-based care. I'm a heart doc by trade and have been practicing clinical medicine up until recently, and moved here to Dallas about 8 months ago. The pressure that's been exerted on the US health system with the COVID-19 pandemic, with now approaching almost 250,000 deaths and over 10 million cases, has had a very significant clinical impact, economic impact, as well as put a lot of pressure on primary practices in primary care, as well as to hospitals. And there has been a ton of learning out of this initial experience. Early on in the pandemic, people avoided any form of acute health care and were coming in late, presenting to the emergency departments, whether it was for COVID-19 with active pulmonary and other manifestations, as well as deferring or delaying acute care for strokes and heart attacks and things like that. As we've gone into this more prolonged, protracted phase, we recognize that there has been a dramatic reduction in quality gap closure, in getting mammograms, and in getting colonoscopies, and preventing care, as well as controlling chronic conditions, and the urgent need for virtual touch points as by phone, text, video, telemedicine capabilities has undoubtedly manifested with a very big way, with over a billion virtual engagements from a healthcare perspective. We are uniquely poised to manage a significant number of our beneficiaries in a total cost of care environment, where the per member per month costs are reconciled, and we are able to invest in the healthcare of our communities with the degree of flexibility afforded to us in Medicare Advantage, as well as under the waiver for participating in a CMMI model. There have been a number of initiatives to align financial incentives for primary care physicians and to extend the opportunity to participate in value-based care to specialists. We continue to score high on quality, and there are some lessons learned that I would love to share with you around that space. But we recognize that we continue to fail our most vulnerable, our medically complex, frail, often home-dependent seniors, and are developing in-home medical care solutions for this population. And finally, what I'd like to touch upon is that there is a silver lining around this pandemic. It has brought healthcare into the national conversation. recognized the need to shift away from fee-for-service and to leverage technology, virtual care, and really put patients in the center of this next decade of healthcare innovation. So I mentioned the immediate burden of COVID on hospitals and on mortality more broadly, but there are vulnerable groups who've been deeply affected. That includes patients who have challenges with social determinants, the risk of coronavirus infections on the obese, our own struggles with managing and improving outcomes in patients with diabetes and obesity, recognizing age as a factor of increasing susceptibility and frailty, as well as the presence of multiple chronic conditions that are ever challenging in terms of being treated effectively, especially in the midst of a pandemic. We all know of the twindemic with the fears that influenza will have a double whammy on the healthcare of our communities, and have a big push to get flu shots out early and scaled across our populations. But very early on in the pandemic, we noticed and we were given information through our local EMS of a dramatic increase and rise in the number of cardiac arrests, as well as dead on scene in the homes when they arrived. And consequently, we also saw a dramatic reduction in activation of a heart attack related cath lab activation. And so recognize that there are vulnerable patients, there are high-risk patients who really need to know to go into the hospital for the onset of any acute symptoms related to strokes and heart attacks. And we got out more than 200,000 messages through leaflets, phone, social media to patients who were at risk based on their ASCVD risk scores, based on other risk profiling tools, based on the presence of uncontrolled hypertension and diabetes, to make sure that their messaging was clear. But we don't know the long-term effects of having so much of delayed, deferred, as well as undiagnosed cancers. By almost an 80% reduction in mammograms, as well as 90% reduction in colonoscopies, it is without doubt that there are patients who are walking around with undiagnosed cancers and will present later than they would have otherwise presented, which will pose another new set of challenges to the US health system. Oftentimes, being in the home with the risk of corona infections, there is a difficulty in controlling chronic conditions, in providing the much needed access and follow-up in primary care, as well as an increase in depression and social isolation as a result of the pandemic. And we recognize that there is some reduction in unnecessary low-value care, but at the same time, there needs to be a balance between deferred care and the quality of life that is also a key component to healthcare. In terms of fee-for-service, it's important for us to acknowledge the difficulties primary care physicians have faced in the face of the COVID pandemic. Dramatic reductions in practice volumes, some like 80+%, have only been in part been replenished or replaced with virtual visits. And so the volume dependency issues with fee-for-service has undoubtedly been a shortcoming. It has not been fee-for-service's most shining moment, in the words of Michael Chernow, who was interviewed by Tom Lee in the NEJM Catalyst earlier, a month ago rather. And so the impact of deferred care on the business aspects, on the clinical improvements and quality of life, as well as the impact to specialists and hospital margins has taken a major toll. There are also infrastructural issues in fee-for-service that we just can't provide the kind of care that we want to provide or the kind of resources that we want to provide to patients, especially during the pandemic, that have been limited in fee-for-service. And there's also, from a regulatory standpoint, limits on flexibility for what we can and can't do. And so having more patients, especially among seniors, in a capitated environment, having greater flexibility to provide them with important programs and resources to address social determinants, food insecurity, and other components of non-medical care have been really important in improving outcomes as well as total cost of care. And you really can't capture as much of these financial gains and associated efficiencies in a fee-for-service model as in a two-sided risk model. But even with Medicare Advantage, there are payments that can be impacted by risk adjustment and quality measures, including gap closure, that make it difficult to manage MA patients in the midst of a pandemic. So it's not without challenges there either. As I mentioned, the network that I lead has several advantages, most of all in terms of its overall size. We have over 5,000 providers, and we have a large number of covered lives, and many of those beneficiaries are in fully capitated environment or in participating in the next-gen ACO program. And so we have rechanneled a lot of our margin into investing in our utilization management that really is also being transformed as we speak into a much more robust physician-centered decision support and referral management system. We have care managers and care coordination teams, including a social determinants and social worker team. And we leverage the quality, the risk adjustment, the network efficiency as part of our financial incentives to physicians and to provide as many benefits and resources to patients. And of late, we have developed a greater analytics around med-econ, really understanding the drivers of these medical cost trends and addressing them with new programs, initiatives such as pharmacy, as well as care of the medically complex patients through in-home services. So what does success look like in terms of aligning our provider incentives? For primary care physicians, especially participating in APMs, we reward quality, risk adjustment, the use of a network efficiency platform, as well as providing access and attribution in terms of the number of covered lives and outreach to patients. We certainly support those activities through our own care management team, as well as use our analytics to identify vulnerable populations and medical cost trends that we can address with better decision support as well as tools. We are recognizing increasingly that the window is sort of narrowing on specialists in terms of the opportunities to participate in ACO level, but have also recognized that with the mandatory models coming out around oncology, around radiation oncology rather, around ESRD treatment choices, that the direction from a bipartisan approach is really around making more bundles part of the healthcare ecosystem, many of which will become mandatory as we go forward. And so we're developing this new what I would call forensic cost accounting to allow for this subcapitation opportunities, to create the right financial incentives for participation in the bundles and creating virtual bundles, including exploring the future of what commercial bundles would look like. And doing that in the context of driving really better care within a more narrowed network, and applying really best practice and clinical transparency principles to our in terms of transforming it into a best-in-class referral management system, as well as a post-acute care environment. But ultimately, we will struggle with managing these patients who are just so dependent and have high risk, high cost, and medical complexity. And so we are developing a home-based model that will launch in 2021. Similarly, we have a pharmacy optimization program that's coming online, and will actually focus on several key components, including specialty pharmacy, including med adherence, de-escalation programs, especially around the biosimilars and identification of biosimilars rather, and really focusing on symptoms control and disease progression and disease management as part of a pharmacy optimization plan. In terms of doing work around transparency, our focus is on reducing unnecessary imaging. I know there's been a decrease overall in access and utilization in the midst of a pandemic, but I think the time is right now to really identify and separate out what we consider low value care and to socialize that amongst physicians and patients so that they understand where the duplication can be avoided and where testing may be unnecessary, especially with institutional programs like those around back pain and other programs. I want to take a minute to share an example of us closing quality gaps in the midst of a pandemic. We recognized that there was a shared savings opportunity in one of our contracts to be able to avail of this only after reaching a quality gate threshold. And this aligned with our overall philosophy of continuing to close gaps in quality and focusing on chronic conditions. And so we provided financial incentives to physicians for gap closure. We also simultaneously got vendor support to get out into the homes of these patients to do eye scans, to do blood work, to obtain the necessary referrals for mammograms that were done close to home at identified sites that would provide timely and safe support to have these procedures done. And so we created this toolkit for physicians, helped them have the prescription signed, actually used tools that we have not used before for getting these scripts done, such as DocuSign, and then getting the information into the hands of our vendors to be able to close the loop, and simultaneously doing outreach to patients in terms of recognizing the need to not delay care, especially around preventive testing during a pandemic. Some of that work now is going to be scaled, especially as we go into the flu season and want to dramatically have flu shot compliance, as well as focus on controlling chronic conditions in a broader population. I talked about our need to accelerate recognition and treatment and interventions for high cost, high needs patients. In our own cohort of about 88,000 seniors who had a high MARA score, we recognized that about 10% of them were costing the equivalent of the remaining 90%, with almost 3 times the readmission rates, 5 times the ED utilization, and 10 times the hospital admit rates. And so based on strict eligibility criteria, as well as the need to provide greater support for social determinants and address medical complexity and symptoms control, we have instituted, or going forward to institute, an in-home medical care model focused on geriatric population. We also have helped to leverage telemedicine across our entire network and actually stood up the telemedicine program pretty quickly when the pandemic first hit. This has really provided important reprieve to patients and satisfaction amongst our physicians to continue being able to provide the much needed access to patients during the pandemic. And so as we now come to the end of the year and look ahead, fee-for-service is not only at a point where it is being questioned in terms of the future of healthcare and the total cost of healthcare, but really being questioned in terms of being ineffective to provide the necessary infrastructure and payment models to care for populations in the face of a pandemic. And so our shift to APMs in terms of greater two-sided risk, greater flexibility is something that is actually being welcomed by the physician community. We recognize the need to create functional teams, virtual where needed, and to partner with specialists, especially around the development of bundles and advancement of bundles for financial alignment and opportunity. We recognize the need to align financial incentives with the goals to optimize quality and clinical care for patients, as well as optimizing network efficiency so that we can really drive the best care in a more narrowed network. We recognize the need to engage with patients as well to improve quality outcomes and control of chronic conditions, as well as in terms of preventive care. We are continuously failing this high-risk, medically complex population and really need to provide timely virtual and in-home services, and we're going forward with that. And in terms of, timely care, we can't underscore the important need to make virtual care, especially telemedicine visits and payment for telemedicine made permanent. We know in rural settings that has recently been enacted, and we wish to see that that continues through action through Congress for us to be able to make permanent the things that were in the waiver for the pandemic. And ultimately, the only way we're going to understand our populations better is with the use of data sets that allow and spurn this revolution of biopharma research and scientific collaboration using AI to really improve the health and outcomes of the population, and to identify specific segments that we can address and even prevent disease from happening. So with that, let me just end by saying there is a silver lining that COVID brought, and the outlook on healthcare from my perspective is definitely a brighter tomorrow. Thank you so much.